All right, we're back. Another podcast for the Digital Healthcare Podcast. I'm with Andres Mellik, co-founder and CEO of Cognuse. So, Andres, thanks for joining us.
Thank you for inviting me. Glad to be here.
Yeah, a little bit of trouble getting to Vegas, but he made it, and he's ready to roll. So, talk about the company. I understand there's two parts and two main areas of focus. So, maybe kick off just at a high level of both of those.
Sure. So we started Cognuse already back in 2012 in Europe, and in Estonia, where I'm originally from. And then in 2013-14, we jumped to the US, simply because it's essentially like a larger market, English speaking. In Europe, there's like more than 40 countries, different cultures, languages, regulations. So for us, it made sense to come over. We did the Dream It Health Accelerator in 2014. We also did the 500 startups back in 2016, and then raised in that time frame our first seed round of funding, around $1 million US. And we were primarily focusing on improving sort of patient outcomes and rehabilitation already as early as possible, so in the intensive care units. And we're working with some novel concepts like early mobilization and early rehabilitation in the ICUs, and worked with or a couple of health systems on the East Coast as well as in the San Diego area, where I used to do research like 10 years ago, so I had an historical connection there. And we did that for about 2 or 3 years. In the meantime, the Society of Critical Care Medicine also came out with the guidelines supporting that. And then while working with patients and family members, we realized we had somewhat neglected the clinical staff, who was also a big part of the patient's recovery, at least in the inpatient space. And in 2017-18, we put an extra focus on making sure that some of the content we deliver, but also the clinical content, that it actually is being adhered to. And what we found out was that it's not being adhered to, and there are two major reasons for it. One is it's inaccessible when and where the clinical staff needs it, and the second part is it's really sort of they can't digest it because it's a 20-30 page lengthy, cumbersome document, and they can't find the sort of the actionable information that they need.
Who'd you say it was? That was the healthcare provider?
Yeah, so on the hospital side, so the nurses or the providers, the clinicians and physicians, sometimes the caregivers. So the content really was not basically it wasn't built for real time at the point of care delivery.
Gotcha.
So that's now the second issue that we really want to solve. So make it shorter, but keep the evidence base within it, and then deliver it conveniently in real time at the point of care. And that's what we've been basically building for the last couple of years.
Gotcha. So I want to go into both of those in more depth in a second. How did the company come to be then? Did you recognize there was a clear problem that you kind of started the company that was the main driver?
Yeah, so we started actually in the outpatient space, and it was primarily had to do with cognitive rehabilitation. So things like serious gaming for post-stroke, post-TBI recovery. And so that's where we started from. We couldn't build the type of traction that we would have liked to, and it was also it was very early. So it was we were playing around with some of those concepts already before starting the company in the US. So it's 2010 to 2012, and kind of before the digital health boom.
Sure.
But those serious games actually still exist. We did some interesting clinical studies on that as well. But then when we came to the US, what we saw was how expensive obviously the whole healthcare system is, but where most of the inpatient spending is in the ICUs, and the more acute it is, the more expensive, and also the more complications occur. So we wanted to see what are kind of other methods that we can employ so that we can mitigate those complications or prevent them from happening, or simply providing the patient with more therapy, more support involving more people in the care loop, such as family members,
Mm-hmm.
which is a kind of a neglected resource actually, for a number of reasons. But so what we do is we empower them to be involved as well, basically as care team members.
Sure. So let's unpack then. If you had a stroke or some sort of debilitating healthcare incident, what's the experience like now? Like what would a typical patient go through, and then what's the problem that Cognuse is able to mitigate?
So I think the typical problem, probably worldwide, is that like I'm pretty sure in most ICUs patients are taken very well care of, and they get a lot of attention. They do get a lot of therapy and attention in those settings. Now the problems occur at the day of discharge, release. What do I do next? So what we try to do is, if they're introduced to our tools or solutions already in the hospital, they can actually take those home with them, so they can continue the sort of the family member empowered, let's say, physical therapy, speech therapy, cognitive therapy. So we want them to have those tools actually recommended by the hospital.
And right, just to pause right there. Right now, you probably get discharged from the hospital, and then it's like, here's your packet of papers. Go follow this.
Yeah, go find a rehab facility.
Yeah.
And then obviously, patients are not taking enough control over their own health, so they neglect even those suggestions, and that basically results in long-term disability. And I mean, the earlier you intervene and the more therapy you get early on, the better for the long-term outcomes. So that's a very well documented notion. So we want to support that in every way we can. I did have I turned 40 this summer, but so hopefully I'm years and years from those types of problems. But I did have those. One of the essential motivating factors for doing these things was I could see this with one of my uncles as well as my grandmother, how inefficient those processes were, and because we had already built some of that serious gaming type software, then making sure that is transferred throughout the continuum of care became kind of obvious. So that's what we really wanted to focus on.
Okay. So how does the app actually work in practice then? Is it an actual mobile application or through the clinical workflow?
Yeah, so it runs from a technical point of view, it runs both on sort of native platforms like tablets. You can also just access it through a standard web browser, and it's something that gets introduced to the patients and their informal caregivers already at the bedside. It's basically 30-second, maybe a 2-minute learning curve for them.
Sure.
And then they can kind of jump in, and the clinical team can actually make sure that the content that they see there is curated, so it's safe for them at that moment in time. It's relevant for them. So both the therapeutic content as well as what we call the learning center, so that they can learn about their condition and the potential therapies. So they, like somebody who had a stroke, we're not showing them any content around brain tumors, for instance, even though both these patients might be in a neurosurgery ICU. So and then they can take that application home with them.
Sure.
And depending on the hospital, whether the hospital recommends it to them, and they become basically like consumers paying for our service, or if it's a reimbursed thing and the hospital sees value in it, like maybe preventing readmissions with the same diagnosis, then they can pay for it. So it's up to the healthcare providers actually.
Okay, and you said the healthcare providers do have access and log in and help kind of set up the tool for the patient.
Yeah,
that's a big part of it.
So it takes about 2 minutes per patient to set it up, simply to make sure that the relevant content pertaining to that patient is there, and from there it's basically kind of autopilot for the patients. Sure. And family members.
So is the goal, I guess you're really, whatever the outcomes you're trying to achieve aren't different from the clinical or the healthcare provider's goals, right? You're just trying to create a tool.
We basically try to, I guess, enhance or amplify whatever they're doing. So just to make sure that the patient gets more therapy as much as possible. Obviously, there are levels of therapy which can be harmful for the patient, so we don't want that. But then also this tool also enables us to collect kind of soft measures or almost anecdotal feedback from the patient. Things like, for instance, pain scores, how happy were they, how many repetitions did they do, how did they feel during those repetitions, were those repetitions painful, and that can be filled out either by the patient or the family member. The family member can even work with the patient if the patient is passive, meaning unconscious. So, lots of kind of options there.
Okay. And the team member is probably a pretty critical component, because I know I've had family members that have had health scares, and I know that's the worst feeling in the world when you want to contribute, you want to do something, but there's just not really a good mechanism besides sitting by bedside in the hospital.
Yeah, and well, actually, I mean that was one of the driving factors. We've talked to, I think it was a physician at Vanderbilt, and there was like they basically agreed with us 100% that like, if you see somebody just sitting on a on an acute floor, an ICU floor, you want to put them to work. Like that's the physician's like natural tendency. Like, why are you sitting here? Like, go do something useful, meaningful. So they want to do the same thing with family members, and obviously, I mean, family members are scared and they don't even want to touch the patient. But it's actually, I mean, even this SCCM guidelines, like, there's good information, and it is safe. You're not gonna do any harm. And any type of additional therapy helps. So you should just jump in and do as much as you can. And I mean, I personally would love to do it. I mean, I didn't have the chance to do it with with either of my relatives, simply because I wasn't in the country when those things happened. But I mean, I would jump in for sure.
Yeah, and
because, I mean, things like I think elderly patients might lose as much as 2% of their muscle mass per day in the ICU. So if you can do anything to mitigate that, that might prevent somebody from ending up in a wheelchair if they do recover. And it's very hard to recover from being in a wheelchair for an elderly person. So anything, so anything helps basically.
Does the app accommodate a family member or someone, a family or friend, working through the app but being virtual, or is it primarily used for someone that's there and able to assist in the?
Yeah, so we've had that question before actually. Like, can we provide some type of remote assistance if the patient is in the hospital, but then we can have like a kind of a real-time link to the home, for instance. The only issue for us there is, some of these privacy issues, like creating an actual video link between obviously the patient can do on their smartphone whatever they want, but if it's a hospital provided system, then, looking at the ICU from outside the hospital, basically, some legal issues. But
Sure.
But I guess, like an HIPAA compliant chat or something is, which I suppose text and video is probably doable. So.
Sure.
Yeah.
So talk about the patients then, because I imagine, obviously I've never been through a stroke or anything as serious as that, but I know it's got to be borderline terrifying for the patient and the family members. Do you find, I guess, is that your goal for the platform, is to help kind of get through that initial scare and start a workable plan and provide some hope?
Yeah, I mean,
is that fair to say?
Essentially, like, I'm an engineer, like a computer engineer and an electrical engineer as well. So I look at most things as like signals and data. And I mean, I'm not autistic, but basically, like, if there's a time to do something, and so I literally look at it as objectively as, would you spend that time being scared, or would you spend that time doing something actionable, something useful? So it sounds like a no-brainer, but like when the fear has taken control of you, then it's hard to get out of it. So what we try to do is provide them with this very simple, very kind of easy on the eyes type of user interface that actually engages them from like, what is this ICU bay all about? Like, why are these nurses, running around or like doing their daily rounds and so. What's up with the medications? Why there's so many of them? Things like that, and then essentially step by step take the kind of the age of the person, and then begin with the therapy, the additional therapy. Then begin with gathering the patient-reported outcomes or experiences and so on. So kind of so the first step is mitigating the fear, and then it's like basically driving action. So
Okay.
yeah.
So switching over then to the other offering that
Mhm.
the company works on,
Mm.
just elaborating on the problem a little bit more. So I think what you said is that there's a lot of tools or medications or
Mhm.
just parts of a healthcare professional's process that they go
Yeah.
through that's just not tailored for the
Um,
high intensity, high urgency setting
yeah.
that it actually is
Yeah.
applied
Well,
in.
so essentially it's about the content. So the guidelines, the protocols, even down to the like a simple checklist level. And what happens is that everybody knows that that content has to be there for compliance reasons and so on. So what ends up happening is there are large publishers of that clinical content, obviously. The Elsevier's and the Walters Kluwer's up to date, and they're doing a great job creating this reference content, basically. And then the hospitals are generating their own content and rules and processes and so on. And like hundreds and hundreds of them, and they're struggling first of all to create them, then to maintain them, and then also to disseminate or distribute them to their workforce. And so what we really want to do is, because of those reasons, that there's an information overload, the content is inaccessible in reality, and when you do find it, it's not something you can consume quickly or understand or comprehend. Then it just doesn't get consumed, and that basically drives guideline non-adherence, which then is directly correlated with like unwarranted care or
Yeah, just
deviation in care.
poor outcomes.
Yeah, and poor outcomes, and that in itself results in even medical errors. So
Mhm.
we think that's very harmful for the patients.
Sure. Yeah.
And
I would imagine
so do
so.
many other people. So what we want to do is we want to really make sure that we can transform that content with, again, instructional design methods and things like that, but preserving the evidence base and then making it consumable at the point of care and in real time through either a nurse's smartphone or a hospital provided one, or it can be a visual interface. But we've also done some sort of good experimentation with voice guided interfaces so that it's actually hands free. They don't have to touch anything. They'll basically request a procedural guide or aid with their own voice, and then they go through and then the system basically supports them in real time, step by step, in nursing procedure, medication dosing, whatever it may be. And we can then use the same stuff for kind of empowering, for instance, caregivers maybe to do more of like a nursing task. We can empower nurses to do maybe more on this kind of a provider clinician side of things, so that they feel confident, comfortable.
Sure.
Some of the kind of the soft measures also are like less burnout. If they're confident, if they have less doubt in what they're doing, and less stress, things like that. So that really is the kind of a driving factor.
Do you? So is it twofold then? It's creating a or some sort of functionality to be able to surface the information,
Mm-hmm.
and then also distilling the information or repurposing it.
Yeah.
Fit.
So repurposing is the first step,
Okay.
and then basically the delivery is the second step. We've seen many of the hospitals we talk to. We've seen them trying to make the first step on their own, like because they've realized like that that type of content is not something they can easily uh, push out, and also like they can't even measure compliance because nobody's even touching that content.
Right.
So they've made efforts to make that easy. So we provide the tools for them to do that, so that which have those methods incorporated. And typically, how we work with the hospital is we'll have a 3-month build-out process where we take the most critical and challenging areas that the hospital wants to improve, and we bring up let's say a number of procedures on the platform as a case study for them, and then we give out the know-how and we give them the tools so that they can continue on their own.
Okay.
And we basically just charge for the whole software platform as a service.
Okay.
Yeah.
Why does I'm always curious because whenever I talk to startups and I hear their problems that they're solving, so many of them seem so obvious. Like this one, it seems like someone I kind of think the reason we're in this situation is no one has clear ownership of how the stuff is used.
Yeah.
But I get why. Do you have any insight on why this problem even exists in the first place?
So I think, I think it's essentially someone at the hospital. Let's say they address a problem. They have a problem with some type of infections. Then the typical way a hospital deals with it is they release a protocol for preventing infections,
Mm-hmm.
and literally it's a enforcing it is much harder than
Because it's
like
so
releasing
rigid.
the actual document.
Just because it's so rigid. And
Yeah, and you have to make sure everybody gets it. You have to make sure everybody goes through it, understands it, and then starts complying
Mm-hmm.
with it. So, and if you take a typical day of a nurse, like a 12-hour shift, for instance, she has her hands full of procedures, taking care of patients, doing what she has to do, and sort of consuming that type of material on the side, whether wherever that is delivered to, often to their inboxes, which are just full and cluttered, and they never look at their inboxes anymore. So like a quality management system sending out notifications,
Sure.
it's just a black hole basically. So we want to make sure that doesn't happen. Yeah. So it's more like you could call it actually like a knowledge base or knowledge management problem
Sure.
rather than a clinical workflow problem, but it does affect both sides. So yeah.
So, from a company standpoint, talking through both the offerings, you've been around for a handful of years now. How much learning has happened and evolution has happened
As a
as what
company?
you've learned, yeah,
Yeah.
over the course of the years?
So
Because it seems like you're in a significantly different place than when you started,
yeah,
just based
yeah,
on how you've communicated
yeah.
it.
So when we started, let's say in the U.S. first, like I literally came, just I had spent maybe 1 month doing like a roadshow of what we had back then, and like I didn't even know any of the acronyms that were being used there, like the whole jargon and the system itself, obviously very complex. So it took 6 months to kind of familiarize at least with the basics
Yep.
and start speaking somewhat the same language. Not to mention the English is not my first language. So it was very difficult, but obviously, and as any startup, we were very naive in the beginning, of course. Like, what is an outcome of a good meeting, for instance? Like, usually it's nothing. So, no, I mean, completely, it's like maybe 2% of those meetings lead somewhere. But we were able to still, sign early contracts and kind of partnership or development and actual paid contracts, which was great for us because we basically like were complete outsiders in that sense. But I guess the product and the vision and like the kind of the empathy of the team also had something to do with it. So, and now obviously it's much more, we are much more focused on looking at what are the top 3 priorities for that hospital. Does what we do align with their overall strategy or like the priorities? Um, is there a financial incentive for this? Because if there isn't, then it's extremely hard to sell it. Or can we find something comparable? Like if it's a quality measure, can we find something that they're spending on quality and compare it to that, so that they can at least find a budget line to put that contract under? Because if they can't, then like, and if they're not accustomed to buying digital health, which most hospitals probably are not accustomed to buying yet, so it's a very it's almost like impossible. So that's I guess those have been the learnings, and getting much more pragmatic, getting much more I guess actually sort of brave about doing things, just sitting down with executives on like 10 billion, or maybe not the CEO but the VP of innovation or nursing quality. So those are becoming more and more frequent for us. So, but we are still a very small company. So
Sure.
yeah.
So you talked about your analytical mind and kind of how you process the world earlier. Was starting this company just kind of a no-brainer and something that you recognized the need and went into it, or did you spend a lot of time figuring
Well,
figuring
I
it
thought
out?
yeah. So in the beginning, because I had done some work in embedded systems and even things like semiconductor tests back more than 10 years ago, which were very engineering heavy domains. But I had also run an e-learning solutions company before. So this is not my first company, and I thought that the educational technology or the education market is tough
Yeah.
to have new technologies introduced, but then I found out there's also healthcare, and so that really made my previous life look like a
Walk in the park.
walk in the park.
Yeah.
But luckily, we were able to bring many of those thoughts and experiences and even technologies down to the standards level of how do you create unique learning paths for students. You can use the same kind of what do you call it?
Thought process.
Yeah, same thought process for patients, like guiding them through their recovery, or maybe for even for a nurse, right? So nurses might adjust the way they do their job, and depending on the procedure, the sequence of steps is not always super important. So like if you prepare for a procedure, it doesn't really matter in which order to put the things on the tray, and what matters is that all the things are on the tray when you go to the patient, so you don't have to run back and forth. And obviously, if you're doing a blood transfusion, the steps are extremely important. So one of our partner hospitals has decided to use the product Coners, which is the guideline adherence product, for all of their blood transfusions, so that not a single mistake ever happens, and it's double checked every time, and so on. And so
that's helpful. Do you find, as the company CEO, do you spend a lot of your time just talking through what we've talked through, like the healthcare aspects of the company, and how do you balance that with everything else, financials, the culture, people, all the other typical entrepreneurial things?
So obviously, as being one of the founders, I also have to really drive a lot of the product vision as well. Not so much on the development side, but just what are the most beneficial, I guess, features or modules, elements of the product. Yes, we do have to do a lot of explaining as well, even to hospitals, because they're just not aware of everything that's happening. And I mean, this conference obviously would be beneficial for all of the hospital CEOs in the world to attend. I mean, I think the mix of talks and sessions and even the technologies on the expo floor, it's just incredible. And it's a very good mix of those elements, but they don't know.
Yeah.
And the other problem is that what I'm always talking through is that each hospital is often trying to invent something that is hospital very similar to them down the road is doing as well. So there's this huge waste in repetitive effort, rather than or thinking like we have a very special setting, or it's like our ICU is completely different from the hospital next door. So if we can unify that somehow, then obviously it will help guys like us quite a bit. If they already find a solution like ours, and then just all of them come to us, or if we build in, or if we recognize the need for flexibility, which we did for the content part. So we gave hospitals the opportunity to have their own content on the platform. So, and that has helped us a lot, because now they don't have to. They sort of connect to us much better, or what we're doing and how we are fulfilling their needs. So, but yeah, I mean, the endless talk about how the healthcare system is complex, and the sales cycles are super long, and you'll run out of money, and like even to the point where like don't raise venture capital, try to do it on non-dilutive grants until you get to a certain level. I mean, those were concepts that actually, especially the non-dilutive and the VC part, nobody was talking about it 5 years ago. But then 3 years ago, everybody started talking about it, because the VCs were seeing that there are no 5-6 year exits in this space. So let's pump it up to like 10 years, but like de-risk early on somehow, some other way. So yeah, we've been all through all of those discussions.
Yeah. So would you say, is the company in a place, you're kind of through that initial, I've talked to a bunch of entrepreneurs, startups, and it seems like at least one or first 2 years, you're kind of just in learning and building that foundation. You're past that. And so what's the future look like, or what are you focusing on in the next couple of years?
Because we do have a very focused product. Technically it's a product that you can actually sign up for, I guess, online as well if you want to. But what we are really looking for right now is sort of strategic partnerships with health systems, or even maybe numerous health systems which have some type of a common element, so that we can address them in a more scalable way, so that we don't have to go with this particular type of product to every hospital, but rather have kind of channel partners, whether it's a large healthcare technology vendor who already has some type of an information system in place, whether it's an EHR or maybe it's a critical care, like a specialty system. That's possible. We also talk to some of the pharma companies, so that if they have a new drug and they want to make sure the dosing and everything is precisely right, again, ours is a system that can assist them in doing that, and they have their huge sales network, and essentially it's more like we're not a digital therapeutic per se, but basically it would be like a companion app for that drug. But by doing so, we can actually also introduce the rest of the stuff. So they are buying a medication dosing, let's say, guideline adherence app, or maybe they get it for free, but then they realize, oh wait, we can use it for supporting our nurses, caregivers, clinicians, even patients and family members.
Yeah, anything that helps get patients taking the drug, right?
Exactly. Well, hopefully it's a drug they have to take.
Right.
Like not something that,
is optional.
Yeah.
Yeah. Well, great. Thanks for covering all this. Is there anything else that's noteworthy that you maybe want to close on, or that we didn't touch on that you think about or focus on quite a bit?
Well, for us, I think it's primarily also playing the game in terms of, how payers looking at this, the insurance companies, because the major issue that we're focusing on is non-adherence to guidelines, and that's one of the major drivers of unwarranted care variation and things like that. And it is an internal concern for hospitals, and it doesn't always necessarily involve the insurance, because especially with bundled payment, the hospital just has to manage on their own basically. So, but if we talk about the whole continuum of care and the payers supporting the patients or their populations throughout that, so if we can actually, let's say we call it co-nurse for the nursing staff, but we might as well call it co-patient for the patient that gets discharged, then is there maybe a financial incentive or benefit for the payer as well to basically continue that path of adhering to the best possible care pathway or like a guideline down the road. So that's kind of the next step for us.
Great. The question I've been closing on with everybody that I've talked to this week, being at the health conference, it's clear that technology and healthcare are on this collision course, and it's even, I guess it's clear to me that that collision's happening now. Can you talk about your experience and the energy that you get from just being a part of the healthcare transformation at this time?
Well, it's true. It's health systems get bombarded with all types of technology now, and there's a huge trend in increasing funding for digital health, and that's, as I think one of the guys on a panel mentioned just a few hours ago, was that he got 300 meeting requests from companies like us for this conference, and he basically ignored all of them, deleted or blocked or whatever, because for him it's noise. So, and that's one type of collision. Like maybe 10 years ago he had only, I don't know,
20, 30.
Yeah, maybe 10 manageable inbound requests, and maybe he met with all of them. And now the kind of the irony is that there's more technology available. There's probably much better technology available, but there's now this barrier of actually getting into the right rooms, stores, people's heads,
processes.
So, and I'm sure many hospitals have actually built sort of protective walls around that, and the IT and the security, privacy. So all these things matter. But yeah, I mean, it is a collision course, and what we have also done is we have experimented with different models to overcome that. So we'll sell directly to the patient or the family member in a literally like in a consumer setting, and then kind of not hope, but then project that maybe they will take it to their provider, saying I'm using this cool technology, and vice versa. So
sure.
So we have to look at all these avenues. We can't just bet everything on
Yeah.
black or red, or if we're in Vegas. So and then the zero comes. So that's the worst case scenario.
Vegas for you
Yeah.
in a nutshell.
Yeah, so
Great. Well, thanks so much for the time and giving me the rundown of the company and what you're doing.
Thank you very much for having me.
Yeah, no, best
It was
of luck
great.
in the future, and enjoy the rest of the conference.
Yeah, thank you.
Thanks so much.
Thanks.